We are so thrilled today to welcome you all to the next exciting and inspirational episode of Concorde Conversations. This is a new initiative by Concorde Medical Group to educate, empower, and encourage our community about our health so we can all live to our fullest potential. Today's discussion is the period demystified. We are joined by two fabulous and brilliant gynecological providers, Dr. Rachel Friedman and physician assistant Pauline Higgins. Remember, we are giving general guidance. If you have a particular question about your health, we'd like to help you. So come in for an appointment so we can answer your questions and give your health the attention it deserves. Let's begin.
Well, I think there's several reasons. First being there are just certain areas of your body that you can't see yourself. It's very difficult to do your own pelvic exam. You can't do your own breast exam. Those things need to be done by somebody else who knows what to look for. In addition to the cancer screenings that we would discuss, and I generally ask people all about their menstrual health and their gynecologic health. And honestly, sometimes people don't exactly know that there's a problem until I ask. So for all of those reasons, oh, and one more also to get some, anticipatory guidance about, what's upcoming in your gynecologic health, what's normal, what's something that you should bring to the attention of a doctor.
So there's always something that's very uncomfortable about even making the appointment for a GYN exam, but we're in a safe place and no judgment-free zone here. So do feel comfortable with saying anything to us. Over the years that we've been working in women's health and advocating for women, we've probably heard it all. So there's probably not anything that could really surprise us at this stage. But two, if you really still feel uncomfortable, then you can always send us an email through the patient portal, maybe before your exam as to what you might want to discuss, or afterwards if you still feel like you didn't get the answer that you wanted.
Well, I think it's an interesting question, and what I usually tell my patients who ask, like, when should my daughter come in, I usually tell them, there are a lot of pediatricians who are quite comfortable with adolescent gynecology, and a lot of patients who are willing and comfortable to talk to their pediatrician about that. Having said that, a lot of women and a lot of adolescents don't feel comfortable to talk to their pediatrician about that, and I think so when these concerns arise, generally 17, 18, I think below that would need to see us. There's a area of gynecology, adolescent gynecology. They have sometimes very specific problems that I might not deal with, but I think, and people shouldn't wait till they're sexually active. I think, really, you need certain information when you need it. So I would say when you're basically at that point where you need gynecologic information, want gynecologic information, and you are no longer comfortable, or your pediatrician isn't no longer comfortable, when you want to come in. So menstruation is a shedding of the uterine lining, and it happens approximately every 30 days. And what happens is during the first half of your cycle, your hormones start to rise, your estrogen levels start to rise, and gives your ovaries the signal to release an egg. Now, we're born with all the eggs we're ever going to have, and starting at puberty, we start releasing an egg every month, approximately. And once you release that egg, it makes its way down the tube into the uterus. And one of two things happens: either the egg is fertilized and pregnancy occurs, or it is unfertilized. And what happens is your uterine, all of the hormones again rise and then fall, and your uterine lining, which has been built up, then sloughs, and the whole thing starts over again. So it's that whole cycle of basically releasing an egg, having the egg mature, having it make its way down, and then the hormonal fluctuations that build your uterine lining up, as if perhaps there could be fertilization. That uterine lining needs to be built up to help with a pregnancy. But in general, no pregnancy, then you have a slough lining, and that is menstruation. You can ovulate without having a period, because I think if you think about all the different steps involved in ovulation and having a period, there could be a situation in which someone's uterine lining doesn't build up and doesn't slough. So your body may be giving you the signals, maybe releasing an egg, and not you may not have those same changes in your uterus. So I think if you're not getting periods, and it's not for a reason of like a contraceptive hormone or something like that, if you're not getting periods, I don't think you can assume that you're not ovulating. I think if you're in a situation where you're trying to conceive and you are not getting regular periods, that's something you would want to reach out to your doctor about, because I think generally regular cycles are ovulatory, and irregular cycles, that question needs to be answered with your physician.
Well, typically if you haven't had your period for a couple of months or cycles, right, we consider that to be amenorrhea, and we'd like to have you come in to be evaluated. You can have lighter cycles or infrequent cycles, and that would be considered oligomenorrhea. Again, something that if you've had regular cycles in the past, we would want you to come on in to be evaluated for. And then menorrhagia or hypermenorrhea, where you're bleeding very heavily. And if that's out of the ordinary for you, and that your cycles haven't been that way, we want to see you. And typically we, say that if you're bleeding more than, say, or changing a tampon or a pad more than once an hour and it's saturated, you definitely want to be in here. Did you want to add anything?
Not really. I mean, I think that generally we ask people what if they've had any changes from what they usually have had, because everybody sort of just knows their own cycle. So I have some patients who actually, when I ask them the details of how much they bleed, I'm like, oh, wow, that happens every month. And they're like, yeah, that's what things are like, So I think it's hard when you don't, not everybody is comfortable to talk about their periods and how heavy or light they are or whatever. So I think if you notice changes in patterns, it's important to bring those up too, because sometimes you're just not sure. People live with a lot of things that may or may not be worthy of investigation. Again, I would go with the changes for you. So any changes in your menstrual cycle, heavier, lighter, bleeding in between your periods. And there are times that these things can be normal, but they need to be evaluated for certain situations, because there are times that they cannot be normal. And I would say an increase in pain in your cycles, an increase in what your change in what your ability to do and function around the time of your cycles.
So there's many different types of birth control. The most common one that we prescribe is typically birth control pills. And most women like that because they have some kind of control over it, right? Starting and stopping it and how they feel on it. And there's so many different options within oral birth control pills that if you're having some side effects to one, we can obviously switch you to something different. So there's a lot of room, a lot of options. IUDs, or intrauterine devices, are the most reliable methods of contraception that we have available, and some of them are non-hormonal, or I should say one is non-hormonal, and then we have a few hormonal choices, and they can protect you against pregnancy for up to, from 3 to about 10 years, depending on which type that you have chosen. There are rings that deliver hormones that you can use once a month, patches that you use once a week, which are really very helpful if you're not in the mindset of taking something on a daily basis. Injectables that you can take once every 13 weeks or once every 3 months. You'd have to come in for us to dispense that for you. And implants, right? Like Implanon and Nexplanon that you place underneath your skin, or we place underneath your skin of your wrist or your underarm. And then there's a whole host of non-hormonal methods like withdrawal, condoms, diaphragms, cervical caps, spermicides, films, Phexxi that changes your vaginal pH, right?
Yeah,
To make
it just came out. It's one of my patients told me that her Hulu is like inundated with Phexxi commercials. Mine is not, so it may be like a matter of what you watch. I don't know. But Phexxi is a vaginal gel that you put in a little bit before intercourse, and then basically it alters the pH. So these things may or may not be right for you. A lot of it, like when I'm thinking about birth control for one of my patients, I ask them like, if there are other non-contraceptive benefits that they might want to get, ask them about their periods and what they're like, if they're painful, if they can remember to take a pill every day, if they can put a ring in. You said people have various limitations, I would say, or things that they want to get from it. And I think what's super important about that is like, I don't want to give someone a pill if they are good with taking pills or they know they're not going to remember. So just being sort of honest with each other about what is going to be most effective, because obviously whatever you use that you can use most reliable is going to be most satisfactory.
And then there's always emergency contraception that's available.
Yeah.
And you're never married to one particular kind. So if you try something and you don't like it, then that's, another reason to let us know that and, work with you to try and figure that out. Because not everybody knows the first time out what you're comfortable with.
And each method has different sort of pros and cons. So we try to tailor it, but some of the sort of side effects, they can be limited in nature. So, if you are experiencing a side effect with one of these things, make sure you reach out, because I have had a lot of patients discontinue a method thinking, oh, well, I don't like this. This is annoying. But in reality, maybe it would go away if you waited for another month or two. And so, a lot of methods may take a little bit of an adjustment. And so having an open dialogue about that is important. In general, everybody is really different with the way that hormones affect them. So, these are generalities. And I mean, the research about weight gain in the pill just has never shown any association with weight gain. And my understanding is the only method of contraception that has been documented to have a small amount of weight gain, like 0 to 5 pounds, is the Depo-Provera.
Right.
And that's obviously something that, people care a lot about. It's important for your health, but generally, no, most methods do not, and in pills in particular, should not be associated with weight gain. So, your libido and your sex drive is a broad multifactorial concept. So it's like not just hormones, it's not just one thing, but hormones certainly can affect libido. And there are some I would say all pills in general can bind testosterone in your body, testosterone being one of the hormones that is related to libido. So when it's bound in your blood, your body doesn't see it as much. So it certainly can affect libido. It can decrease libido, but there are some pills that are a lot less with that. So if that's something that you notice, it's maybe possible to change your pill to adjust to that. But again, there are so many different reasons for decreased libido. We certainly want you to bring that to your doctor's attention, because, a lot of times it's not someone's pill.
Oh, absolutely. For heavy periods, for painful periods, we use it. Some people will also use it, again, maybe not the most medical way, but to alter their periods. If something is coming up that they would like to avoid having their period at a certain time, that they will start perhaps taking birth control pills or something along those lines to kind of delay it or something along those lines.
Well, I mean, I use that medically too, because I have a lot of patients who, some people have their periods are so painful that you can skip them altogether by skipping the placebo. So a lot of times we'll counsel people to do that.
Sure.
Also, there are a lot of medical disorders that may not be caused by hormones, but are exacerbated by hormones.
Headaches, right?
Yeah, headaches, arthritis, a lot of different things. And so I have a lot of patients that's an adjunct to their treatment plan overall, is to eliminate those hormonal fluctuations.
All right, good.
Oh, I was just going to say we were asking other benefits to contraceptions, right?
Yes.
Like, for example, the pill decreases your risk of ovarian cancer by 50%. So a lot of people who have a family history of ovarian cancer or a genetic predisposition are on it specifically for that. Decreases your risk of uterine cancer. And I have some patients who use it for acne. It can help with your skin. So there are a lot of different reasons people will use it.
So mid-cycle is typically ovulation, and being that there's a range of the length of your cycle, how we determine that is based on your cycle length, right? So if you can take the average and 16 days back from when you predict the next one. So for a 28-day cycle, that would be day 14. And typically ovulation will occur a few days before that to a few days after is what we tell women to try to avoid or to try to increase if they're trying to become pregnant.
So menopause is 1 year of no period, and as we mentioned before, when you're on the pill and skipping your period, if you don't have a period for a year, that's not menopause. It's unadulterated and no other reason for not having a period. Average age is about 51. Premature menopause is defined as below 40, and what generally happens up until menopause, I would say, like, late 30s through your 40s, would be something called perimenopause, which is kind of like a general decrease in estrogen in your body because, as we mentioned before, you're born with all of your eggs, and your ovaries produce estrogen throughout your life, which has many bodily benefits and downsides. And what happens is that levels slowly decrease, and so there's no specific lab test that can tell that, because what happens, I try to think of it as like your ovaries are kind of stepping on the gas to release an egg every month. So when you're in your mid 20s 30s, your body has to lightly tap on the gas, and over time, as you have less eggs and you're producing much estrogen, your body has to sort of step on the gas a lot harder. But we don't, even if so, what our lab levels that we would do of hormones could reflect that your body is stepping on the gas harder, but it wouldn't necessarily predict menopause, which is the cessation of menses for 1 year. So I think it's actually a really good question, because I would love to be able to predict for people when that might happen. But some people, as they approach menopause, there's, like Pauline mentioned before, they skip periods or they come closer together. But that can go on for years for a lot of people. So it just kind of depends, what your body does.
So the first one I think that most women will notice is irregular bleeding, maybe prolonged cycles. Some women will have heavier bleeding, hot flashes, night sweats, insomnia, inability to concentrate, and vaginal dryness. Those are all, or any one of them, hopefully you don't have all of them, but any one of them, would indicate that you're approaching that.
It's really variable. I find that some people really don't have very many symptoms and aren't really much troubled by it, and some people really go through it. So I generally will talk about treatment for each individual symptom that comes up, that Pauline was mentioning. I try to address it because there are a lot of sort of local ways of addressing it, rather than necessarily using a systemic medication. So I'll usually start lower and then raise my degree of medical intervention. For hormone replacement, which, as we were mentioning, that your body ceases to produce estrogen from your ovaries, it gives your body back those hormones, and basically simulates what you had before menopause. And I will generally use hormones for people who have menopausal symptoms that really interrupt their quality of life, that they can't manage in other ways, because there are a lot of ways to manage. And I would say in particular for hormone replacement, the biggest indication that I use it for is hot flashes, for people who have really hot flashes that, they have difficulty sleeping or they have difficulty working, really that interrupts their quality of life. The risks of hormone replacement, it is a hormone just similar to contraception, birth control, has cardiovascular risks, high blood pressure, stroke, blood clots in your legs or your lungs. And so, you have to sort of pick the right person. The patient has to have the right medical background to make sure that those are acceptable risks, and kind of weigh the pros and cons for each person.
Yes. Yes, no, I think it's important if you have hypertension or any cardiovascular disease that you talk to your cardiologist about starting it as well. Because we will work with your gynecologist to make sure that you're safe with these things. Here's a question from the chat box. I heard it's normal for teenagers to have heavy and irregular periods. Is that true?
Well, it can be early on, but again, it should kind of regulate itself. But if it's not, or they're having any additional symptoms like pain, or they should actually be seen, just so that we can ensure that that's the case.
Well, I kind of think of, I don't know, did you ever learn the popcorn analogy?
No.
So basically, I mean, this is obviously, I'm going to look old by saying this, but like those Jiffy Pops, no one makes these anymore, but like the Jiffy Pops that like you put on the stove and they pop, 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 when you first start. So I think of it as the like sort of reproductive cycle, sort of like that with the release of your eggs. So you start with the
Right.
Jiffy Pop, and in the beginning, it's kind of like random pop, pop, pop. And I think that's what's happening with ovulation. Right. And then you get into a rhythm, then it's really going. And then at the end, when you're not quite sure, it's like right. Random again, right. And then I think of that. So I think to some degree, like the, beginning of puberty and menopause are like the beginning and end of the Jiffy
right.
Pop.
They're very similar.
Yes. Yeah. So I think, it's always good to ask. I think it can be normal, but certainly there are situations that it could be abnormal.
All right, here's another question from the chat box. Can a lot of physical activity affect the regularity of your period?
I'll do that one. No.
Well, no.
Okay.
Yes.
Yes, I think it definitely can. Yeah, because I think what we know about your period, a lot of it depends on your estrogen levels, and we have estrogen in our adipose tissue or in our fat. So, a lot of time people who engage in vigorous exercise, in particular, like elite athletes, like right. Olympians, a lot of times get no period because they have very, very low body fat. So I would say that that's the relationship. Actually, right. And also, sorry, one more thing I forgot. If you, also, in addition to exercise, being grossly underweight can be another reason why people might not get periods. A lot of times I sort of think of your period as almost like a sign of your overall body health, because I think, when you, like, for example, in my patients who have disordered eating, a lot of times the cessation of menses is related to body fat and nutritional status. Yeah. So exercise can be related to that in some ways.
I think to exercise, just not too much.
Yeah, I think so. I think exercise, there are benefits in every area of medicine. I specifically gynecologic benefits of estrogen or of exercise. They both start with an E.
Yeah. Is maybe helping with cramping pain. Definitely less body fat as we reach menopause can be very helpful.
Bone health, it can keep your bones strong, and that's another effect of estrogen in the body is when you come to menopause and you're not making estrogen anymore, maintaining bone health and decreasing your risk for osteoporosis is really important. So exercise really plays in there.
Yeah.
Pre-pregnancy also, like for making sure you maintain normal weight. If you're thinking about a pregnancy or pre-pregnancy, that all decreases your risk of like diabetes of pregnancy, high blood pressure of pregnancy. It actually increases your chances of having a vaginal delivery, meaning like avoiding surgery. So there are a lot of benefits probably throughout your reproductive cycle.
Yeah. So that's all great advice. So thank you everyone for watching another amazing episode of Concorde Conversations. This has been really fascinating and educational. We've tried to answer a lot of your questions, and we know many of you have many more questions. So if you do, please come in for an appointment. We're here to help you. We care. We want you to do well. So thank you so much for joining us today.